that.
What a mouthful, isn't it?
Yes, don't worry, I'll explain what it is. Right, yes, so, yes, my name is Simon Boyd, and this is presentation number 2 for my diploma. And so we're going to look at the case where I had some interventions to make. So it's a lady who had it's quite a mouthful, idiopathic thrombocytopenia, purpura, and psychotic depression. So I'll explain what those terms mean further on as we go on. So the patient was a 39-year-old female who had hypothyroidism, which was well controlled. She also had psychotic depression, which was well controlled, and then she had this chronic idiopathic thrombocytopenia, which I'm going to call ITP from now on. So I'll have to keep on saying that. So that was the condition that wasn't well controlled, and it's managed by hematologist in Aberdeen. So we'll just look at some history. So relevant psychiatric history. So she was diagnosed with psychotic depression, and I'll have to put the year in. It was about 10 years ago, so kind of 2007. And then she was put on citalopram 30 milligrams once a day and aripiprazole 20 milligrams once a day. And she'd been on that for about 5 years or so, which had kept her kind of symptoms under control, and actually treated it into remission. And she wasn't even kind of at that time on the kind of CMHT kind of caseload, because it was just well managed by the GP and she didn't have any issues. So, looking at ITP, what is it? It's actually a bleeding disorder where the immune system will kind of see platelets as foreign bodies and will attack them and destroy them. Mm-hmm. So in your body, platelets usually survive for kind of about 8 to 10 days, and the spleen kind of, after they get a bit old, the spleen goes over a bit, kind of getting past it, breaks them down, and your bone marrow replaces the ones then that are destroyed. But then, because they're treated as foreign bodies, when it goes to the spleen, it goes, oh, there's some antibodies in that, that's a bad thing, I need to destroy it. So it destroys the platelets. So that it can be reduced down to as little as a few hours that the platelets survive. So the bone marrow makes them, they go around the kind of blood stream and go through the spleen and get killed pretty much straight away. So there is one of the medications, and it's called Eltrombopag. And so this kind of boosts, your kind of bone marrow to make more of these platelets. So what do you think the consequences of not having enough platelets might actually be?
Imagine you're prone to infection.
Pardon?
Prone to infection?
Possibly, yeah. What do platelets do in the body? Do you know?
Is this general?
This is a medical thing.
Oh, I'm the only non-nurse here. I'm thinking, is that hemoglobin in the platelets?
Well,
psychiatric
platelets.
nurses.
Oh, yeah,
Let's make that perfectly clear now. We're psychiatric nurses.
Thank you.
Is it not about carrying sort of oxygen and things? So
No,
the
that's
tides-
your
red ones.
hemoglobin, that's your blood cells.
Yeah.
But, good try.
Yeah,
No, platelets are what's involved in your clotting.
Clotting.
So, kind of, even if you have like a scab or something, that's made up of platelets, kind of just clumped together. So if you don't have enough of those, then you're more at risk of kind of bleeding and kind of, or like nosebleeds and things like that. So if you have a low number of these, hematologists don't get worried until they go below 50. Well, 50 by 10 to the 9 per litre. So let's look at what hers were, kind of one stage. So last year, kind of from July all the way through to October, they kind of usually hovered around between 10 and 25. And even then, hematologists aren't too concerned because usually there's enough reserve there that you're okay. But in October last year, she fell to 8. So whenever it gets below 10, that's when they usually think that right now's the time to actually introduce something to kind of try and boost it. So that's when they started in the Eltrombopag, and that was started on the 2nd of November, which is where kind of I come in. So there was a pharmacist at the health centre got a letter from the haematologist saying that the patient had been started on the L-Trombopag, and whenever they put this into their system, that it kind of to their repeats, it flagged up in their system there was a problem with like QTC prolongation, possibly with the citalopram she was already taking. So they kind of contacted me and said, "Oh, what do we kind of do about this?" So I said, "Well, let's do an ECG." Because if you have a prolonged QTC, then you've increased kind of getting, a fatal arrhythmia. As such as Toussaint de Pons, which is a French thing for quite a serious arrhythmia, which can eventually be fatal. And the kind of evidence that citalopram is well known to increase the QTC interval, and it's kind of dose related. It's why the citalopram maximum doses were reduced from kind of 60 milligrams to 40 milligrams, maybe about quite a few years ago now actually. And also why the dose in over 65s was reduced to the maximum from 40 to 20. And then L-Trombopag in healthy volunteers doesn't show any increase in QTC, but apparently in actual people who have ITP, it can prolong your QTC. So there seems to be something to do with the L-Trombopag and actually interacting with the disease condition that prolongs the QTC. So recommended that an ECG be done, and we can then pull off the QTC interval from that. But that wasn't the most concerning thing from my point of view. I don't know if you've heard before, but SSRI, so your citalopram, can actually have an effect on your platelet function. Whenever you take a serotonin reuptake inhibitor, and it obviously stops serotonin taken into cells. So platelets actually have serotonin uptake and reuptake kind of as part of their role. So they take up serotonin and then release it whenever they come across an injury, which was part of the clotting cascade. So the patient already had a condition that caused the number of the platelets to kind of be lower, and then we're given in something that actually reduces the effectiveness of the one she actually already had, and she didn't have any to begin with. So as well as acting in the brain, they affect the function of the platelets. And then whenever the serotonin is released, when they come across this injury, it promotes vasoconstriction, so the blood vessels narrow, so it reduces your loss of blood, and then also promotes the platelets kind of sticking together. So you have less platelets, they're less sticky, which is a problem kind of thing. So what do we do? So we got an ECG to ascertain the QTC, so that was probably a minor issue that needed to be dealt with, but it could also be a major one if the QTC was significantly prolongated. And then we got the patient in for an urgent review, because this is something that can't really wait. Because she's sitting there with 8 by 10 to 9 platelets, and depending on our response to the medication, it might take a few days for that to actually go up. So I brought them in, had a chat with them, and just told them what the risks and benefits of continuing the citalopram were, based on the effect on the platelets. And then also we thought we needed to investigate potential drugs that could be used in place of citalopram if you stopped it, that wouldn't have the same kind of effect. So, what did we expect from that consultation? So, well, I would have expected that we got a QTC interval from the ECG, and then we would have looked at the medicines. I also thought we would have stopped the citalopram due to the effect on platelets, and then I thought we would have started on another antidepressant. But also as an aside, I mean, just to make things slightly more complicated, L. thrombopag can cause kind of abnormal liver function, and kind of also hepatotoxicity. So as well as looking for an antidepressant that didn't affect platelet function, then we were looking for one that maybe wasn't cleared out by the liver or didn't affect the liver in any way. So we were slightly constrained what we could use. So looking at the actual outcomes that we did get, so we got a QTc interval of 430 milliseconds, and the range for kind of the upper limit in men is about 440, and in women in this case it's 470. So there wasn't, too much worry with that. So that wasn't really an issue. And then we stopped the citalopram due to the effect on the platelets, and also then that would probably bring the QTc interval down a wee bit as well. After discussing with the patient the risks of kind of maybe stopping or continuing treatment, then they were offered an antidepressant, but they decided at that time that they wouldn't go for that, and they would attempt to kind of just go without it and just stick to aripiprazole. So they advised then if the mood did deteriorate, then they could call in GDCPN or go to the GP and ask them to refer back into the service. And whenever we sent a letter to the GP, informing them of kind of all the changes we've made, we did say kind of mirtazapine was probably the one to kind of go for, because there is no effect on the QTc interval, and also there's no effect on the kind of bleeding risk with respect to the mirtazapine. And then also mirtazapine is affected by the liver, but if it goes up, if the level of mirtazapine goes up, the risk is quite low, because the other options that we would have to maybe consider is something like nortriptyline, because we're looking for something that doesn't affect your serotonin directly. So mirtazapine affects it indirectly, and nortriptyline works in noradrenaline. So those are the two kind of main systems that are used that are affected in mood disorder. So your serotonin and noradrenaline. So if we had went for nortriptyline, it's quite badly affected by liver, and also if the level of that is raised, then your risk of adverse effects is significantly increased with respect to the mirtazapine. Does that all make sense?
Mm-hmm.
Yes. Okay. So, looking at our actual outcomes, so the patient actually had quite a good response to the L. thrombopag, and their platelets kind of went up, so that's quite good. So now we're looking at, your hypothyroidism is well controlled, and your ITP is well controlled. The mood did deteriorate, so mirtazapine was started and titrated up to 30 milligrams, which they actually got a good response to. So kind of looking at all three conditions, are well managed and well controlled. So do you have any questions about that? That was there's quite a lot of pharmacology in there.
Oh, that was interesting.
So, if you had any questions about that would be good.
I just want to say sorry, but we had a double booking for a patient that's already been asked to come back. So I want a quick summary.
A quick summary.
So,
yes, there was a patient who had chronic kind of idiopathic kind of thrombocytopenia.
I think I was involved.
Yes,
with the
you were.
patient.
Remember
Okay.
we got them in for a review,
Yeah,
an urgent review the next day,
Yes.
and they were on citalopram,
yeah.
and we stopped the citalopram, and I think at that stage she decided not to go on another antidepressant.
Yes.
So, and then we wrote to the GP and let them know and said if
Yeah. Now I've got the patient in my head,
Yes.
so that's fine.
yeah. So it's just a kind of brief summary of that. That's what of
Yeah.
what we did and why we did it.
And that it's very important to consider clotting effects and platelets, because we had another patient
Mm-hmm.
that had a DVT, a proper economy class syndrome for flying back, had a pulmonary embolus, and then was put on, first of all, warfarin, He was first he first had
Oh yes, Datapan.
yeah,
Yeah,
and then he
treatment
was
of
put on warfarin,
Mm-hmm.
and he was on escitalopram.
Mm-hmm.
Okay.
And the escitalopram and the warfarin didn't go together. So we stopped the escitalopram, left him with nothing.
Oh, he was on lithium, I think, wasn't he? I think
Yeah, he
was
was on lithium as well.
So, I think he decided at that stage that because
Yeah.
he would have been quite
Yeah.
stable.
Yeah, but
Yeah,
he was a patient that really dipped low when he went low. He was admitted to Aberdeen and all that when he was really unwell. He was previously was a solicitor. He lost his practice in the process of going high, and then he went really low and all that. So we continued on the lithium. We took the escitalopram out, but then his mood dipped. We also left him without antidepressant. And then it was a true liaison case. We, Dr. Fryer agreed to see him immediately when we needed to reintroduce the escitalopram, and he went on a low weight
One of the new
one of
ones.
the new anticoagulants. So because Dr. Fryer agreed to take him off the warfarin and put him on the newer medication, we could put him back on escitalopram. That's always worked for him. And it's just a bit of, you always have to do all these other stuff.
So how
And if you-
regular would you need to be checking somebody's platelets then if they were on citalopram or?
Well, see, it doesn't actually matter what the number is because
Okay.
it just affects the effectiveness of
Oh, the
them.
effectiveness.
Yeah.
I see.
You know, so it doesn't actually affect your number of them.
Oh, okay.
And also then something to bear in mind if you've got somebody who's on an SSRI, who's also maybe on like ibuprofen and things like that, because then it can increase your risk of GI bleeds and stuff.
Uh-huh.
Oh, yeah.
Okay.
So maybe kind of saying actually maybe not, try not to take that, maybe take paracetamol and things for like pain relief and things like that.
There's a guy I
Um,
worked with a couple of years ago, and he'd been started on sertraline and then citalopram. And one of the reports that he said was that he kept having nosebleeds.
Mm-hmm.
And he said you need to get the GP to check the platelet level, and it was 4.
Oh.
He was rushed off to Aberdeen, but they didn't know whether it was caused by the
By that.
medications. As it wasn't, it was pre-existing.
Yeah. Yeah, because it doesn't tend to affect the level, it just affects the effect. So even the low number that were probably not
But it was
doing
the
very much at all.
nosebleed. Every time you went on the antidepressants, it was
And
the
that's why
nosebleed that was the
they
indicator.
don't just check the levels with the full blood count. They actually check the bleeding time.
Mhm.
And long ago, when I worked in Africa, we actually tested the bleeding time in a tube. You turned it around to check when it started clotting.
Well, I think it's slightly more advanced than that now, but I think that's still
The
the
principle
proviso
is still the
same. Yes, I mean,
That-
so it's put in a machine, but I think the machine
Yeah,
just does that.
Yeah,
That was
Very
just
much.
after you tasted the urine. The next step, you still did you did your slides for malaria yourself. You counted the white cells yourself. you swang off to get the hematocrit. So that you had a side lab that you could do things yourself. Much more
I thought you
hands-on.
actually meant tasted the urine.
In the old days they did.
Yes,
That's why
that's
it's
for
diabetes. That's why it's diabetes mellitus.
Yeah.
Honey
Let's-
urine.
Let's bring this back from
Oh.
South Africa.
Okay, good. Back in the first world.
Yeah, so any more questions
Cool,
about
thank you.
the kind of case that I presented there?
No, that's interesting.
It's probably just something to be aware of. I mean, if somebody's
Yeah.
on an SSRI, just have a look out for
Yeah.
the main things that may also increase their bleeding risk, like the NSAIDs and aspirin. Also your kind of newer oral anticoagulants, like your rivaroxaban and dabigatran and things like that. So.
And one tends to forget that around pregnancy and delivery, there is a huge amount of hormonal changes, but there's also a huge amount of changes in the blood, because when you're pregnant, the blood dilutes, and then when you unpregnant, the blood concentrates, and that is a risk for DVTs and things as well. And if we work in perinatal, it's important to take that into consideration, because nowadays if a patient is immobile, like after a cesarean section, they do give dalteparin. And then if you have a patient that restarts on antidepressants, or that you have to give antipsychotics or antidepressants for during a postnatal period of severe mood changes, then you also have to think the other stuff around it. So it's not always the one thing. And like this other newer patient that we've got, Laura Hodge, we just saw her today, who had a third loss of pregnancy fairly late on. She had the psychotic.
Yeah, I'm
Yes.
going to trying to turn that off.
Delete that.
Aye.